Hi, I'm Dr. Derek Lee. It's my pleasure to introduce Dr. Peter Newton, who's the Chief of the Division of Orthopedics and Scoliosis at Rady Children's Hospital in San Diego. He's also the clinical professor at UC San Diego School of Medicine, which is where you did your residency as well, correct?
Correct.
All right, welcome.
Thank
Now,
you.
my first question to you is, you seem to be a little bit of a tinkerer, hands-on, working on cars, a very mechanical brain, right?
That's true.
Now, your degree was in bioengineering, and with that mechanical brain of yours, was that a natural transition into the mechanics of the spine and eventually to being a spine surgeon?
I would say yes. You're right. I started in engineering, but I got some early exposure to orthopedics through a summer research experience, doing some biomechanics research around knee ligaments, and that got me interested in orthopedics. And so I ended up going to medical school and coming back to UCSD for my orthopedic training. And the Children's Hospital here has always had a very strong orthopedic program. And so I got exposed to pediatrics during my residency, and I really enjoyed working with kids and helping parents just make sure their family's doing well. And then got more and more into scoliosis as my career developed. But I would agree that the mechanical side of that training does help me both in my research and in my clinical practice to think a little bit more about how spine deformity can be measured in 3D and how it can be analyzed, as well as the corrective forces required to fix scoliosis.
Yes, I'd love to ask you some questions about your 3D research. It's pretty fascinating because I know you've written or you've participated in over 200 publications, and it's quite the list, and very diverse as well. So trying to narrow these questions down was a bit of a challenge for me. Now, when was your first exposure to the concept of vertebral body tethering in terms of trying to find a non-fusion approach?
Yeah, well, I had early in my career gained a lot of experience in the thoracoscopic approach, which is an anterior minimally invasive approach through the chest to get to the spine. And so I had a lot of research running in that area in probably the late 90s. And as that was developing, I was learning and developing methods to do thoracoscopic fusion using that method. And the concept of growth modulation is very common in pediatric orthopedics, and we manage a lot of long bone limb alignment by modulating how the growth plate grows using temporary plates to slow the growth on one side of the leg or the other to help things straighten. So I was familiar with that concept, and I had begun to research the idea of potentially developing an animal model to be able to study growth modulation in the spine, probably around that time. I guess it'd be sometime in the late 90s. And so I experimented with a number of different ways to do that, from little tiny rabbit models to bigger bovine models.
It's interesting because you were actually into the animal model stage at that time. So
Yeah.
Okay, I didn't realize it was that far at the origin of the concept. So from there, I guess you were familiar, obviously, with the research. What was the next step in terms of getting into actual tethering, I guess?
Yeah. Well, I probably did, it must have been more than 10 years worth of research in this area, trying to, really the first was to validate whether or not the spine growth could be modulated the way we modulate lower limb growth. And that became pretty clear pretty quickly. The next question was, if you do that, if you put a flexible element along the spine like a tether, and in these cases we were using sort of metal cables rather than the polyethylene that we use today, what would happen to the disc? Because all of I think the premise for all these non-fusion ideas is that the disc, which is so important in movement and mobility of the spine, would remain healthy and physiologically functioning. And if we put this tether and cross the disc space with it, and it caused disc degeneration, that would not be fruitful. It would just defeat the purpose. If we kill the disc in the process of growing the spine straight, obviously it doesn't really help us. So I studied a fair bit about the physiology of what happens to the disc when it's put under those asymmetric compressive loads. And we know from other studies that if you compress the disc without allowing motion, the disc degenerates. And so there was a lot of people who had great concern about that might happen with a tether as well. All of our animal research suggested that that was not the case, and the disc would tolerate this compressive force as long as you allowed it to continue to move. The nutrients that are supplied to the disc by compression distraction, and that motion is really what drives nutrients in and out of the disc, could continue. So that was encouraging. And then I guess the next area was just that we realized that there was an implant system that had been brought from Europe to the United States for non-fusion treatment of low backs that provided us the things that we needed to do tethering in children. And that was an FDA approved device for use in the low back, but not for use in children for tethering, of course. And so the rules around physician-directed use of product in this quote off-label or physician-directed use allows that to happen. And so several of us in those early days realized that system could be utilized for tethering. And so we got started with kind of the right patients with who were interested in trying to find out if that would be a reasonable solution. And so I don't know, my first patient must be almost 9 years ago now.
Fascinating. Now, you brought up so many different points of interest in that one statement. So let's go back a little bit. I had no idea that they actually used cables as opposed to tethers at the beginning. And talking about tethers and their breakage rates and all that, is it not being done using the cable just because of not enough flexibility, or what's the reason?
That's a great question. Yeah, I think this idea that the tether, that whatever material that we use to be the tether needs to be durable, and that the current methods that we're using, we're finding tether breakage with a fair bit of frequency, particularly if you watch long enough. The metal, though, was always thought, if we used a metal cable, that those metal fibers would fatigue and break. Because, metal, if you bend the coat hanger over and over and over again, obviously the coat hanger still breaks. And unfortunately, if you tie your shoes over and over again, your shoelace eventually breaks too. So I think both of those have a risk of fatigue and failure over time. But I would also lay out there that I do think that there's probably some materials that could be designed better to last longer and be more durable. Whether it will be a metal cable or some sort of synthetic plastic or polymer, it's a really interesting question. And I think it's a material science question that our industry folks are going to have to help us develop.
And of course, there's a bit of a range in terms of opinions on disc and disc health, because as you know, because I was, when I was taught as well, because there's no blood supply to the actual disc itself. It all depends on compression and distraction and movement in order to, pump out waste products and suck in nutrients, right?
Correct.
So some surgeons feel that if you even touch a disc, look at it the wrong way, and make a small incision even, then you basically destroy the integrity of the disc. Yeah. While others feel that perhaps if it's a severe curve, the disc is already compromised. They're trying to reduce the anterior column and to get a better correction. How do you, where are you? Well, I guess I know where you are on that path, on that spectrum, right?
Yeah, there's no question that if you, the animal models are very clear that if you incise the annulus of a disc, depressurize it, that leads to disc degeneration. And it's really the animal model by which we study disc degeneration, is puncture the disc with a needle and study that loss of disc physiology. In my mind, if you incise the annulus, you have destroyed the integrity of that disc, and that the normal physiology of pumping that fluid isn't possible anymore. And I'm very certain that that leads to disc degeneration. Now, the secondary question, however, is even if the disc degenerates in a human in which you've done that, does it lead to pain or other issues down the road? And I would say that question remains unclear. There are certainly advantages in the correction of scoliosis that occur when you can shorten the anterior column. And when we did anterior fusion surgery and took the disc out purposefully to get fusion, that shortening was very valuable in restoring the sagittal plane as well as just the three-dimensional alignment of the spine. So I love the idea of shortening the anterior column. I don't like the idea of doing it by causing disc degeneration. And and there's really not been any good study, either in an animal model. The animal data would suggest that if you do that, you're going to have trouble. But there isn't really been any good study of what happens if you incise the annulus, and then what happened to those discs down the road. And you're right, there's controversy there. And one of the proponents of that, Dr. Betts, I just had a conversation with just this week about that particular topic. So obviously he's got ideas that the disc can tolerate that. It doesn't fit what I've traditionally been taught regarding physiology of the disc. And so it's going to take more work before I would ever be a proponent of that approach.
Fair enough. Now, a question as well, is there, well, in terms of mobility, there's a difference between lumbar and thoracic in terms of flexibility, range of motion. Is there a difference in the disc in those two locations, or they're pretty much the same?
Well, I would say you're correct that the motion is very different thoracic to lumbar. And in fact, a lot of people who've talked about tethering and the risk benefit of tethering, the advantage of maintaining thoracic mobility is probably just modest anyway, because that segment doesn't move all that much. And the lumbar is where we really have our functional motion in the spine. Cervical and lumbar are the most important areas. So the disc physiology is different, I think, in the sense that the range of motion is quite a bit different. The ribs limit the motion. The rib head articulation actually crosses the disc. And so that alone creates some limit of motion across that thoracic disc. So, and normally the discs in the lower lumbar spine are the ones that typically wear out in all of us as we age anyway, and occasionally thoracic, but not quite so commonly. But people who do have thoracic disc degeneration as well as lumbar disc degeneration certainly can experience pain. And I guess would like to not be creating degeneration in any of those discs if possible.
You understand, especially in an immature spine that's still growing as well.
Right.
I knew that you were on board early as a pioneer in VBT, and with using the tethering and with any new protocol procedure, there's always going to be a learning curve. Initially, what was the major variables in terms of tether breakage? Was it just material science? Was it just trying to figure out what the correct parameters would be?
It's a great question. I don't know that anybody really knows the answer. I do believe that nearly everything we've used in the body, particularly in orthopedics, where substantial loads are going to be borne by the implant eventually fail. Metal in the spine without a fusion fails. And so if you do an instrumentation system without fusion, they tend to fail. Now, obviously, we weren't trying to tether with metal, but and if we could put in a ligament-like structure that was synthetic and it would last forever and ever, we wouldn't be harvesting for anterior cruciate ligament reconstructions or any of that kind of stuff. And we tried synthetics there, it didn't work. So I, to be quite honest with you, never thought, and I still don't believe, that a tether will remain intact forever and ever. It is not
possible.
Not possible based on the science of the materials today. Could we ever get to something where we could build it strong enough? Maybe. But right now, I've never really had an intention that that device could be maintained for a lifetime. And I did think it would last longer than a couple of years, to be quite frank with you, because I did these in animals, big animals that I let go run around in the wild, in their space for years, and for over a year, and didn't see a tether breakage. But in the human, we've seen it now in, I don't know. I don't know if I have anybody who's had more than 4 years of follow-up that doesn't have a broken tether. There might be some, and some are harder to tell, but I would say that the incidence is very high once you get past 3 to 4 years. And probably the earliest one I've got broken is somewhere around 18 months. So we need them to last longer than that. Maybe 3 years is okay, 18 months is not. I personally think that the best patients for this procedure are those in which there's 2 to 3 years of remaining growth, where you can really, truly change the shape of the vertebra in a way that will result in a lasting shape change of the vertebra in the spine that will then no longer be dependent on that cord to hold the disc in a new position. So I think that the idea of depending on the tether is not a good one. So I don't know, but we'll have to wait and see. And I still would like to have more control over when it breaks. I don't like the idea that it breaks when I'm not ready for it to break.
Yeah, there should be a little bit of a remote control
yeah,
device
exactly.
that you can keep in there. Because I was talking to Dr. Sam Bani as well, and he was going, I would like to have multiple breaks happening with the tether once the spine is mature, and that way you're not restricting movement at all.
Yeah, exactly.
And everything is free to move as it should, right? Because I was always interested as well in the early tethering. Were you surgeons already thinking about the parameters at that time? For instance, if you're going towards bigger Cobb angles, then you're going to have, and stiffer curves, you're going to have increase in breakage rates. So was that part of the approach back then as well?
I would say that my initial approach was to only take on patients who would have otherwise needed surgery. So they had to have a curve in the surgical range. And that's, typically 50 degrees. Although there are some patients in the 40s who are failing bracing where that could still be appropriate. And with clearly substantial growth remaining. And so I wanted initially to know, could this modulate growth, not just cause a disc to become wedged and cause, and straighten a curve by tensioning it without actually changing the shape of the vertebra. So I wanted to be able to see and measure changes in growth over time. And so I chose patients who had 3 years of growth remaining. So very immature patients, especially relative to what some are suggesting today. And as a result of that, I would say that nearly universally, we saw at least initial growth modulation as a result of tether placement. Now, some of those we ultimately lost the correction because the tether broke or the curve added on someplace else. But I wanted to really have a very clear understanding of whether or not we could modulate growth. And so my patient selection was for those that were much more on the immature side. And maybe that is actually an added challenge because there's a lot of years to try to predict what's going to happen. And it makes the procedure at least long-term a little bit more unpredictable, but it also established the idea that very clearly we can modulate growth over time as opposed to just, take a curve and make it straighter while you have the tether intact. And I never felt like that strategy would be successful in the long term. So I wanted to have a lot of growth. Curve size is another really important one. So I didn't want to operate on people who weren't going to have surgery anyway, and I still don't. And I knew that the bigger the curve, the less likely we were to be successful. So I guess I went up probably to about 70 degrees in some of those earlier cases, and my current indications have come down. I think we've been even less likely to be successful in curves 65 to 70. So I really do think that, kind of 50 is the sweet spot right now. And obviously you can go a little above, a little below that, and depending on age and growth remaining, you might be able to go higher or lower. Flexibility has got to be a feature in there as well. So I think those are all important variables, and what kind of correction you should try to get on the table in the operating room, knowing that some of that's going to be lost when you stand up, to try to have a reasonable amount of curve that you can modulate away over the remaining years of growth that exist. It's that whole prediction component of this is a piece that we're still missing, and there's obviously lots of folks working on how to do that better, both with really sophisticated computer modeling and also kind of really understanding what happens over time and at what rate do these things change, and how efficient is the tether at changing the growth that we think should be there. So we're definitely making progress with that, for sure. I just finished up looking at a project of what happens at the apical vertebra, that midpoint of the curve where the spine vertebra is the most wedged. Following three-dimensional shape changes of that vertebra over a 3-year period of time, calculating sort of monthly rates of change of both angulation and height change, both on the concave and the convex side, anterior, posterior, is really interesting. And those patients who correct the most, those growth rates are higher on the concave side, as you'd expect. And so it does match what we see clinically. But now at least we have some numbers to say, this is the growth rate that we would expect in a successful outcome, and start to use that rate of change to calculate when to do the surgery and how straight to get it, and try to calculate, based on your age, what's a reasonable curve size that we could anticipate correcting over time.
Well, that's pretty fascinating. I was talking to a couple of the Newton fellows, Dr. Bob Cho and Dr. Mianchi, and I asked them about, are you guys seeing actual evidence of bone modulation in the vertebra in the sagittal plane? And they said, well, we can probably say probably, but you'll have to, they don't want to squeal on your research, so to speak.
Well, I'll tell you, unfortunately, I guess I would say the sagittal plane, from the data that we've collected in 3D, is a little bit mixed. And it is important to do this research in 3D, because if the spine is rotated off to the side, the lateral x-ray doesn't really show you the true sagittal plane. And so you have to have a three-dimensional reconstruction and really look at the vertebra from a direct lateral position to understand how much wedging it has in that local sagittal plane of the vertebra itself, if you will. And in the animal model, we used to get about half as much correction in the sagittal plane as we got in the coronal plane. So the amount of wedging and growth modulation was about half as much in the sagittal plane. So I assumed we would get something similar to that in humans, and that does not appear to be the case. At least our tethering strategies so far have not resulted in that degree of kyphosis restoration that I had anticipated based on the animal models. And I don't exactly know why that is, to be quite honest. I really don't. The idea that you might be able to put the screws a little bit more anteriorly to get a little bit more effect, I think, is the case. And I do have, again, more anecdotal experience than hard science on this fact, but patients who've generated more kyphosis seem to have had their screws a little bit more anteriorly placed, which would make sense. But well, I don't think we've got the sagittal plane figured out as well as I'd like for tether right now.
You and me both. My son is very hypokyphotic.
Is he?
Yeah, even a little bit of lordotic, but I'm sure you guys see that all the time. So
yeah, we do.
And he had a VBT with Dr. Sandani about 6 months ago, and he was also talking about trying to play with screw placement and angulation to see if he can get a little bit more tension anteriorly to see what he can do. But I completely understand that once you see that lack of flexion with a true hypokyphosis, it's, you know, and it's completely, flexion is almost completely rigid, that, you know, there has to be some expectation or reasonable expectation about what it can do.
Yeah.
Now, a question I have as well, since we're on that, you brought up the topic of the 3D modeling. It's pretty fascinating when I read that paper because, you know, we're always taught that, of course, you're going to look at the sagittal plate from the lateral view. And when you brought up the 3D shape and how you can't really tell the actual vertebra, it makes complete sense. But that's why, are you seeing more lateral or coronal bone modulation as expected, or is that also a little bit mixed?
I would say the coronal comes as we would expect, although even in the animal models, when we measured growth rate of a normal animal, then we put a tether in and said, we're going to assume that the tether completely stops that. We should expect this angular change if the other side continues to grow just based on geometry. The tether was not 100% efficient in that way. It didn't get the full effect. And I think that's probably true for this as well. If we know what normal growth rates are for the human vertebra, in theory, we should be able to just calculate the width of the vertebra and what that change is and measure an angle and be done. But it's a little bit more complicated, obviously, because the disc can change in its height. And the disc compression has to be enough that it transmits that force to the growth plate to finally stop growing. And if you really tension aggressively at the time of surgery, you might stop growth immediately. And if you tension rather softly, that effect may lag for months or even longer. And that is kind of our strategy for how we modulate how much effect we get in the coronal plane at different regions of the spine. So in the middle, we want it to get more correction. At the ends, we want to get less correction. And really, the only way we can do that is by putting more tension in the middle, less tension on the ends, and delay when that growth plate on the end will actually will grow enough to see enough force to stop itself from growing. And boy, unfortunately, we're still pretty much guessing on how tight to make something.
I assume that experience is a huge variable in that, in terms of how many patients you've seen and what you see in terms of progression.
Yeah.
A question for you, because I know it seems that many VBT surgeons are trying to correct to 50%, and hoping that 25% more correction optimally. So for overall 75% correction, if things go perfect, right, type of thing. Is that initial 50% correction on the coronal plane, is that the number that needs to be achieved in order to get bone growth modulation going? Or is that just a guesstimate?
Yeah, it's a great point. I suspect it's more getting the initial standing curve under a certain number rather than under a certain percentage.
Okay.
So I suspect that, and I think that is probably also related to the growth remaining. So there's probably a curve magnitude on standing which is too big for the tether to even work. So if you put a tether in and had a 70-degree curve when you stood up, there would still be so much compression on the concavity that it wouldn't grow on the concavity, and the tether would prevent it from going on the convexity, and the curve might not get worse, but it won't get better. But if you can compress it enough to unweight the concavity and normalize those stresses, then that side can start growing again. And I don't think we know exactly what that number is, but I think people would suggest that it's probably in that 30-degree range. Maybe it's 25. And so that kind of comes out to be 50% of the 50 to 60-degree curve that we typically treat.
Right.
So, but I'll bet you it's more a true magnitude of the residual curve, no matter where you started from. And how much growth you need to modulate is largely dependent on how wedged the vertebra was to begin with, and that's related to the original curve size. So the bigger the curve, the more wedging you start with. And so, and again, it may just be that a 70-degree curve has got to be corrected to more than 50% to unweight it, and it's got to be effective for a longer period of time because there's more wedging present in that apical vertebra. So you might need 3 or 4 years of growth to modulate a 70-degree curve. You got to get it down to 30 so it can actually grow, and then who knows? You still might end up overcorrecting. But usually not. I don't think I've seen a 70-degree curve get overcorrected. But
Right.
but obviously the 40-degree curves can easily be overcorrected if you've got a lot of growth left. And I think, but those principles I think apply all the way around. Magnitude of deformity, growth remaining, and getting enough initial correction to restore the forces to a point where the concave side can grow.
Were you involved with the FDA study with Dr. Samdani in terms of providing data or guidance, that type of thing, in terms of parameters?
I've been in contact with the FDA through Setting Scoliosis and Straight and the Harm Study Group with Dr. Samdani, but I wasn't involved strictly in his approval process. Having said that, the post-approval study that is being initiated with the Zimmer Biomet product is being done through the Harm Study Group and Setting Scoliosis Straight, and the establishment of that protocol, our suggestions and the Zimmer Biomet suggestions, and the FDA. There was a lot of conversation about how to design that, what should we be looking at, and how to get it done. So I have been in contact with them a fair bit about trying to make sure that we set that up properly.
That's great, because I was chatting with Zimmer as well, and Dr. Bob Cho actually put me in contact with him because he was talking about how they're training surgeons, trying to make sure that it's done properly as opposed to a bit of a free-for-all, I guess, in terms of usage. So it's pretty interesting that they're going that approach, and I like that they're going that way as well.
Yeah, I do too. I think that is, certainly a responsible way to do it. And, given that the approval for this product was, through the humanitarian device exemption pathway rather than a standard 510K pathway, and suggesting that it's safe with probable benefit rather than safe and effective, which is what they traditionally approve, I think both the FDA and Zimmer Biomet are doing a good job to try to navigate that water. And this is a new procedure for a lot of people. Some of us have had a lot of experience with the thoracoscopic approach or anterior surgery for scoliosis from prior methods of treatment. But for a lot of people, it's brand new. And that certainly the technique of using a flexible element is new. And like most surgeries, picking the right patient is the most important thing. And we always say it's the decision, not the incision, that's so important. And I think that really applies here. And there'll be a learning curve for everybody, unfortunately. But we'll get there.
Okay. What is the perfect patient for you in terms of parameters, like center score and everything?
Yeah, I grade it. That's a great question, and I personally prefer this for thoracic curves rather than lumbar curves. I would love for lumbar curves to ultimately be the curve that we treat, because I do think those are the most important disc and the most important motion segments, as we discussed before. But I'm concerned that the failure rates in the lumbar spine are going to be substantially more than in the thoracic spine, just because the motion is so much greater and the loads are so much greater. But having said that, I've got another strategy that I use for the lumbar curves. But so for me, it's still a thoracic curve. I like the thoracic curve to be substantially larger than the lumbar curve. So In the Lenke curve pattern, I would like that to be an A or a B modifier rather than a C modifier. And depending on the age, I would say the sweet spot's kind of 45 to 55 degrees. I'm game to go a little above that for someone who's got more growth potential. Maybe 60 is still okay. And you know, every time I say 60, then somebody comes in with a pre-op film that's 63 or 4 or 5, and we still go because we made a decision when it was 60. But
Right.
ideally, you know, if you're asking for ideal, I would say, yeah, right around 50 plus or minus 5 is the best. Growth remaining, I am still far on the earlier side of the spectrum than most people. So I think Sanders 3 is probably the ideal. So Risser 0, Sanders 3 is ideal. Sanders 2, I've got many, many patients that I've done at Sanders 2. And again, that's kind of a long phase of growth, so you got to be a little careful about what you say about Sanders 2. But that group, I have some of my best results in, but I also have some of which we've completely corrected and had to have a second surgery to untether because of overcorrection, which is not, I mean, ideally I'd like to not have to do that and figure out how to plan better, but in this day and age, having a full correction is, I feel very, very confident in those patients who I can fully correct and have a tether out, that I'm not dependent on the tether, and that the recurrence is much less likely than if I've got a 20-degree residual curve with a tether in place and it hasn't broken yet, and that each time it breaks, it might creep back up to 30, 35, and who knows, then it might be going again. So, so I would like to try to shoot again for Sanders 3 for me. I do lots of 2s and I do some 4s. I rarely do a Sanders 5.
Okay. Now I have to ask you, what's your different approach for the lumbar that you touched
on? Well, I guess I still tether some lumbar patients, but my primary indication for a lumbar tether today is in a patient who I did a selective thoracic fusion with posterior instrumentation, and I used the tether to help move the lumbar spine back into its kind of corrected position. So I'm not nearly as dependent on the tether for a long period of time. I need it maybe for 18 months to allow that spine to kind of get back underneath and still get a little bit of growth potential. But much of that lumbar correction comes by correcting the thoracic spine really well with an instrumented fusion. And so, but I've been using instrumented fusions for the thoracic spine and lumbar tethers in patients that I would be otherwise nervous about doing a selective thoracic fusion. And so I might have fused them to L3 or L4, and now I'm fusing them to 12 and tethered to 12 to 3 to save the lumbar motion.
No, that makes complete sense.
Yeah.
No, I like that. Do you stick to single tethers, or do you ever go to a double in terms of, because there's some surgeons who would like to reinforce a little bit more, I guess, but that restricts movement even more, right?
I think you're right. Yeah, no, that's exactly true. Some folks believe that if one tether breaks, you should put in 2 tethers. With 2 tethers in place, you really do start to limit the motion much more substantially. And we've looked at the biomechanics on the effects of motion with a tether in place. Obviously, the bending away from the tether is substantially reduced. Bending towards the tether is not reduced at all, and that wouldn't matter 1 or 2 tethers. Rotation is limited about 50% with a single tether. I don't have the data for 2 tethers, but I suspect that really affects that substantially, because now you have a much more rigid linkage, even though it's a flexible element. It's much harder to, you know, when you twist one, it wants to get longer. So I don't know what the effect is, but I guess I would rather find another material than to just keep throwing more and more of these in. And I think now we've got kids who have broken 2 tethers now as well. So putting in 2 tethers isn't necessarily the solution.
Okay. Now, a question about if you're tethering and the child is still quite hypokyphotic and their cervical spine is reversed, it's now also kyphotic. Is there anything that can be really done for the cervical spine, or it's all kind of dependent on the thoracic sagittal alignment?
Yeah, that's a great question. I mean, clearly the cervical spine, thoracic spine, lumbar spine, sagittal alignment is all related to each other. And if you have a deformity in the sagittal plane in one of those areas, that the other areas will compensate to the extent possible. And most of the time, it actually can compensate reasonably well. So I think we've got a lot of kids who are hypokyphotic in the thoracic spine, even after having posterior spinal fusion, where we can really pull it back substantially. And the cervical spine does have a little bit of less lordosis or frank kyphosis, but I don't know. I think for the most part, those kids actually do pretty darn well. So I'm a huge proponent of trying to normalize the sagittal plane. And personally, I think it's more for the lumbar than for the cervical, but your point's a good one. And either area can take a little extra stress and strain over the rest of the lifetime because of malalignment in between either of those. So ideally we get it right, but I also don't know, at least for a cervical spine, I think it's a little bit more forgiving.
Okay. Well, a lot more flexibility there, right?
Yeah.
A couple other questions before I let you go.
Okay.
It seems that the biomechanical model for scoliosis, again, the cause can be quite variable or unknown.
Yeah.
Is, with RASO, or there's so many acronyms for it, anterior vertebral overgrowth, that type of thing.
Yeah.
Where you have the wedging anteriorly, it increases the anterior column, hypokyphotic, maybe lordotic in the thoracic. Then that leads to rotation as the spine tries to unwind or decompress, right? Or just to reduce tension, leading to
get rid of that length. Yep.
Leading to the coronal traditional scoliosis.
Mm-hmm.
Is that the sequence of events? Because I know that some surgeons are maybe thinking that the rotation component, is it a chicken and egg, whether it's what's your opinion?
That's a great question. I think you're correct in that for sure, when scoliosis is established and we've got an operative curve in the thoracic spine, there's anterior overgrowth and the spine is rotated out of the sagittal plane and there's a coronal deformity. I think we're all clear on that. And I think everybody agrees now that there actually is thoracic hypokyphosis. That wasn't known completely until relatively recently, actually. I mean, some people's minds has been there the whole time, but not everybody kind of saw the real data to convince them. But the question of whether it's primary or secondary, in my mind, I was early on very much a believer that anterior overgrowth was the driver of the development of scoliosis. So I was a believer that being anterior overgrowth was primary. The more I study this, the less certain I am of that's in fact true. I believe that there's a major component of that overgrowth that comes secondarily. And that's because you move the spine out of the sagittal plane, however it gets there, primary rotation, I don't know what gets it there. But once it starts to get there, the anterior vertebrae are not loaded to the same extent because our primary movement is in flexion extension. And these things aren't in that sagittal plane anymore, they're off to the side. They don't get the same amount of compression. Mm-hmm. That compression doesn't restrict their growth as it normally would, and so it overgrows because they got less compressive force. And when it overgrows, it rotates even more and kind of that vicious cycle of Stokes takes on. And so I do think that it's both a sagittal and a coronal effect of growth modulation through Hütter-Volkmann, if you will, that is at play. And I was really a strong believer initially that was anterior overgrowth was the primary driver. I worked with met a lot of people who preached that to me through the years. And I'm less certain as time goes, because we see it now, and even in non-idiopathic scoliosis. So if you look at neuromuscular scoliosis or kids who've got scoliosis for other known causes that are not, just this kind of idiopathic variety, right? We see anterior overgrowth in those patients too. So that makes me think for sure some of it must be secondary. Mm-hmm. Yeah, so
when you know
I don't think those patients who have muscle disease get scoliosis because of anterior overgrowth. They get it because they have a muscle disease. Yet they get anterior overgrowth as well. So I don't know if there's both at play in idiopathic, but I'm I'm sure there's a secondary component.
Interesting, because it does make sense if it's already shifting and the stresses are shifting with it.
Yep.
Then who knows, right?
That's right.
Because my thought was like, if the hypokyphosis, you know, the anterior overgrowth is what's driving it, why with bracing are, you know, mild to moderate curves, the braces aren't more kyphotic in order to put more pressure and maybe assist bone modulation, right? But I guess
that's a great question. Very great question. And I would say that we just actually finished a 3D study looking at our in-brace and out-of-brace changes in alignment of the spine using EOS. And we did not do a very good job of even derotating in a brace. Even with a 3D brace design, we still have a lot of trouble doing it. And the reality is, I think it's really hard to apply this sort of flexion force without the spine wanting to rotate out. Because we say that's why it's rotating out in the first place, right? To get rid of that extra length.
Yeah.
And if we bend them, it just rotates them more. So it's really hard to derotate and add flexion to a brace, but that's what needs to be done. And so you're thinking about it correctly in my mind.
Okay, that makes sense. Okay. Thank you so much, Dr. Newton.
Yeah, my pleasure.
Again, anytime I talk to you guys, you spine surgeons, I learned something new, which takes me down a completely different path where I have to research now. Thanks very much.
My pleasure. Anytime. Great to catch up.
Thank you very much. Bye for now.